Very good morning, all of you. Myself, Dr. Kalyani, Professor and Head Department of Pathology. I welcome all of you from Department of Pathology, Sri Devaraja's Medical College, Sri Devaraja's Academy of Higher Education and Research, Kolar. So we are organizing the webinar on transfusion reactions. Yeah, good morning, all of you. I welcome for the today's webinar. That is, the theme is transfusion reactions. We are organizing from Department of Pathology, myself, Dr. Kalyani, Professor and Head of the Department. From the Department of Pathology, Sri Devaraja's Medical College, Sri Devaraja's Academy of Higher Education and Research. I welcome all of you for the today's webinar. For the today's webinar, I welcome our founder chairman, Sri Devaraja's Education Trust, Sri R.L. Chalappa, Sri Rajendra N. Jagadale, Vice Chairman, and Sri G.H. Nagaraja, Secretary, Sri Rajendra J. Administration and Finance Director. I also welcome Dr. S. Kumar, Honorable Chancellor, and Dr. A.V.M. Kuti, Honorable Pro Chancellor, Dr. C.K. Ranjan, Honorable Pro Chancellor for the Health Services of the Academy. I also welcome Dr. Pradeep Kumarji, Honorable Vice Chancellor, and Dr. K.N.V. Prasad, Registrar of the Academy. I welcome Dr. Sriramulu, PN Principal and Dean for the Faculty of Medicine, and SM Hazim Mohyuddin, Medical Superintendent, RLGH and RC, and Dr. Shashidhar Kane, Vice Principal, Sri Devaraja's Medical College. I welcome all the audience, and I welcome the faculty of my department for the webinar. We have selected the theme of transfusion reactions. As you know, blood transfusion is a life-saving procedure, and it's essential for the healthcare delivery. And the protocol for the blood transfusion goes on right from the donor selection and producing of blood, and till the final drop of blood which enters into the the patient. And for the today's webinar, we have selected two topics. One is the blood transfusion reaction. The other one is the hemovigilance. And the first topic is mainly to bring about the awareness among the clinicians and also the nursing staff regarding what the probable blood transfusion reactions can happen in the patient who has been transfused, in the donor. And in the second talk will be about the hemovigilance, which that is regarding the monitoring, reporting, investigation, and analysis of adverse events, and also the documentation of the process of the blood transfusion, which is very important for improving the quality of the blood transfusion services. So hope the webinar will be useful for the audience, and I wish the program will be successful. With this brief note, I call upon Dr. Hema, the Professor of Pathology, Blood Bank Officer, to take the program forward by introducing the speakers and take the program forward.
Good morning, everyone. It's my great pleasure to introduce Dr. Shami Shastri. Madam is Professor and Head, Department of Immunohematology and Blood Transfusion, Kasturiba Medical College, Manipal, Manipal Academy of Higher Education, which is in Manipal and Karnataka. Madam has done her MBBS from Kasturiba Medical College, Mangalore, and MD in Transfusion Medicine from SDPI, Lucknow. She is trained in transfusion medicine, apheresis technology, immunohematology, and clinical transfusion therapy. She has a vast experience of teaching in transfusion medicine, of like almost 15 years. And till now, she has guided 12 postgraduate theses and 3 PhD theses. She has 65 international and national publications to her credit, and she has received many awards. A few of them are Young Scientist Award by ISTM and ISBTI, Harold Gunson Award by ISBT, and she also has several poster and oral presentation awards to her credit. She is a member of various transfusion academies. So some of them are ISBTI, ISTM, and AHTR. She was instrumental in establishing state-of-art Department of Transfusion Medicine and Immunohematology at KMC, Manipal. She was also involved in identifying a rare blood group, that is P null phenotype, for the first time in India. She initiated and conducted G.J. Dolly postgraduate workshops in transfusion medicine, and she also established a regional rare blood donor registry at Kasturiba Hospital in Manipal. Till now, she has completed 13 research projects, and she has 5 ongoing research projects. She is also instrumental in conducting several regional conferences and national level workshops, and she has been reviewer for various national and international journals. Till now, to her credit, she has verified 106 reviews on Publons. So with this brief introduction, I want to some of the ground rules of today's webinar. So all the questions will be taken at the end of Madam's session, and you can type the questions in the chat box. So we'll moderate the questions, and we'll pick out some of the questions, and we'll discuss about those with Madam at the end of her session. Over to you, Madam.
Good morning, everyone. Am I audible?
Yes, ma'am.
Yeah, I have shared my screen. I hope it's visible.
Yes, ma'am, it is visible.
Yeah. At the outset, I would like to thank Dr. Kalyani and Dr. Hemlata for providing me this opportunity to interact with you all. So today, for next 45 minutes in this session, we'll be discussing about transfusion reactions, its diagnosis and management. So let us begin with what is transfusion reaction and further classify the acute and delayed transfusion reactions. And we'll discuss about the signs and symptoms, also the differential diagnosis. In this session, I'll be mainly focusing about the acute transfusion reactions. So any untoward sign or symptom which is unexpected, which occurs in temporal association with the blood transfusion, is called transfusion reaction. We can classify them as acute, immunologic or non-immunological reactions. Under acute immunologic reactions, we have hemolytic transfusion reaction, febrile non-hemolytic, urticarial, anaphylactic, and transfusion-related acute lung injury. Under non-immunological reactions, we have reactions due to sepsis or hypotension, transfusion-associated cardiac overload, non-immune hemolysis, air embolism, and rarely electrolyte imbalance. Under delayed hemolytic reaction, delayed transfusion reactions, we can have alloimmunization due to RBC antigens or HLA antigens, or delayed hemolytic reactions or transfusion associated graft versus host disease and TRIM effect, that's immunomodulation, or non-immunological reactions like iron overload. So if you look at the frequency of transfusion reactions, it can be as common as 1 in 10 reactions. And we generally see febrile and urticarial or the allergic reactions are the common ones, followed by transfusion-associated cardiac overload or TRALI, and rarely delayed hemolytic reactions or the anaphylactic and the severe transfusion reactions like acute hemolytic reaction. So this is the recent summary data of 2019 serious hazards and transfusion report. Here, as you can see in this chart, most of the reactions were near miss or is due to incorrect blood component transfused, which is mainly due to some error. Whereas some of the reactions like TACO are possibly preventable, however, the number is quite high. So we'll discuss these reactions using some case scenarios, and here we have case 1 of a 25-year-old neutropenic patient with acute leukemia and was admitted to the hospital for chemotherapy. Patient's blood group was O positive and 1 unit of Paxil was cross-matched and issued to the patient. Following transfusion, patient developed high-grade fever and chills after receiving approximately 50 ml of blood. So this is a case of fever following transfusion. Now, what are the differential diagnoses for fever following transfusion? First of all, the most severe one, that's acute hemolytic reaction. It could be due to febrile non-hemolytic reaction or transfusion-related acute lung injury, or sometimes it could be due to bacterial sepsis. So in acute hemolytic transfusion reaction or any other type, we begin the reaction workup by analyzing the history and the presentation of the signs and symptoms of the patient. So we need to also take the details of the blood volume administered and the concurrent fluid that is, or the medication that is given, IV line that is inserted, and also if they have used any other devices like warmer or the pressure devices, especially if it is used in trauma setting for the rapid infusion of the blood and blood contents. So fever following transfusion, analyzing the time of onset of fever is important. As you can see in the slide, in case of hemolytic reactions and in sepsis, there can be rapid onset of high-grade fever. Especially in case of sepsis, it may occur within 5 minutes of transfusion. This is because of preformed toxins in the blood component. Whereas in febrile non-hemolytic transfusion reaction, it may occur after 1 to 2 hours of transfusion, and in TRALI, there is rapid rise which is rapid peak, and it can happen within 6 hours of transfusion. The clinical presentations of some of these transfusion reactions can be very similar. Like in case of hemolytic or sepsis or febrile non-hemolytic reactions, patient can present with fever. In acute hemolytic transfusion reactions, they can have hypotension, tachypnea, tachycardia, and also they can even have shock, the pain at the infusion site. And if the patient is anesthetized, then hemoglobinuria can be the only sign that is seen with hemolytic transfusion reaction. Whereas in patients with sepsis, they can have signs of shock, hypotension, and they can even present with DIC. The febrile non-hemolytic transfusion reaction is generally a milder one compared to these two reactions. They can have chills, rigors, tachypnea, and palpitation, etc. So in acute hemolytic transfusion reaction, it is due to ABO mismatched transfusion. So whenever you transfuse A or B blood group to a O group patient, or similarly whenever there is a mismatch, the preformed anti-A or anti-B antibodies will attack the red cells antigens and leading to hemolysis, so the acute intravascular hemolysis. Occasionally it can even happen when you transfuse group O platelets with high titers of anti-A or anti-B to a patient. In acute hemolytic transfusion reaction, we begin the workup by ruling out or checking for any clerical errors, because the literature has shown substantial evidence that the clerical errors or minor errors at a patient identification or labeling can lead to major hemolytic transfusion reaction. So you need to compare the patient identification details on the patient wristband versus the requisition form and the samples that are sent pre-transfusion and the samples that are sent post-transfusion for the reaction workup, as well as the label that is present on the blood unit. So check for the patient details as well as the hospital ID, the unique hospital ID that is there, the name of the patient, age, the ward, etc. Further, the post-transfusion serum hemoglobin can be checked. You can check initially visually, the pre-transfusion and post-transfusion samples can be compared. Normally, the plasma hemoglobin level is around 1 to 4 milligram per DL, whereas in hemolytic transfusion reaction, there can be acute, intravascular hemolysis leading to increase in plasma hemoglobin level. It can be a pink or a bright red in color, and you can use plasma low hemoglobin estimation equipment. Here I have shown HemoQ, which has got a detection limit much lower than the other cell counter, that is around 30 to 3000 milligram per DL. So if the plasma hemoglobin is pink, it's a rough estimation, the plasma hemoglobin is around 25 milligram, and if it is clearly red, it is around 100 milligram per DL. Further, you inspect the bag that is given from the ward for the port, the blood bag, the tubings, the color of the blood within the bag. Also compare the color against the blood tubings and the segments. In case of bacterial contamination, this can be dark in color, and in case of any warming of the blood unit or some non-immune mediated hemolysis, the color of the blood in the bag might change. So thorough inspection of the unit and the transfusion set is very important to arrive at the diagnosis. Further, we do immunohematological testing at the lab. Here we need to use pre-transfusion sample, post-transfusion sample, and the sample that is taken out from the bag. We need to repeat ABO and RH typing, the cross-matching, Coombs cross-match, direct antiglobulin test, antibody screening, and also the antibody identification if necessary. So generally, in case of acute ABO mismatch hemolytic transfusion reaction, we see a gross discrepancy in the blood grouping when you compare the pre-transfusion versus the post-transfusion sample. On repeating the cross-match, post-transfusion sample may show incompatible cross-match, and there can be mixed field reaction on doing direct antiglobulin tests. Further, we can do for other lab investigations like bilirubin. There'll be increase in indirect bilirubin level. It may begin to increase within 1 hour of post-transfusion, and the peak is achieved at 5 to 7 hours. It may disappear within 24 hours of reaction. Haptoglobin level may decrease. LDH will increase. Peripheral smear may show signs of hemolysis like cystocytes and broken red cells, and urine-free hemoglobin can be detected. Gram stain and blood culture is done to rule out septic transfusion reactions, because that is one of the major differential diagnosis for acute hemolytic transfusion reaction. The goal of management is to decrease the load of incompatible blood that is getting transfused. So first of all, we have to stop the transfusion, and further we can even start dialysis if a large amount of blood is already given, and this is to prevent renal impairment. And we have to monitor the patient closely for development of DIC. The hydration, alkalization of urine is done, diuresis is started, and whereas very rarely we may consider IVIG depending upon the severity of the case. For this particular reaction, during further management, we can give plasma and platelet transfusion safely, and further transfusion support should be with ABO matched and cross-match compatible blood only. Very rarely, acute hemolysis can occur due to non-immune mediated causes, like if the blood bag is stored improperly. Sometimes we have seen a case where the blood bag was kept in a freezer compartment in the bedside at the ward level, and if some medical devices are used like improper warmers, the transfusion is done under pressure to increase the speed of the rate of transfusion. If improper pressure is put on the blood unit, even that can lead to hemolysis. If the needle is used of very narrow gauge and the speed of the reaction, the transfusion is quite high, rate is quite high, that can lead to hemolysis at the needle port. And if some solution, the antibiotics or the hypotonic solutions are administered along with the blood, then even that can lead to hemolysis. Let us look into this case of a 24-year-old primie who underwent cesarean section at a local hospital. At the time of surgery, she was infused 1 unit of red cells, and on post-operative day also. It was during a post-operative day, and her hemoglobin was 8 gram per DL. During transfusion, patient complained of some signs like fever, and she had palpitation, and which was followed by decrease in urine output, and patient had hypotension as well. So suspecting hemolytic transfusion reaction, she was referred to tertiary care hospitals, our center, for further management. And on arrival, patient was pale, icteric, and febrile. Her pulse rate was 120 per minute. Blood pressure was low, and abdomen was distended. There was no tenderness, and no other abnormality detected on CVS or RS examination. However, with these signs, the hemolytic transfusion reaction was considered as DD. Her hemoglobin was 7.8, and bilirubin was high. LDH was also raised, platelet count was low, and PTA-PTT was prolonged, suggesting a pre-DIC picture. Again, with these findings, HTR was considered. Blood culture was negative, that ruled out the septic reactions. We did the immunohematological workup. We didn't receive pre-transfusion sample at our center. Post-transfusion sample showed a blood group of O positive, and there was no discrepancy. DAT and IAT was negative. There was no mixed field reaction. To rule out possible antibody-mediated hemolysis, we further did dilution study, and that was negative with post-transfusion sample. There was no evidence of antibody-mediated hemolytic reaction in this case. So we conveyed our negative results to the obstetrician, and simultaneously they carried out ultrasound abdomen, which showed gross ascites, bilateral pleural effusion, and exploratory laparotomy was done under GA. they found a large rectus sheath hematoma and hemoperitoneum also with around 1 liter of blood in this patient. So the diagnosis in this case was massive rectus sheath hematoma following cesarean section, which mimicked hemolytic transfusion reaction. So very rarely there can be a clinical syndrome which is consistent with the intravascular hemolysis and can mimic hemolytic transfusion reaction, but it can be due to some other reason which is called pseudo hemolytic transfusion reaction. So in this particular case, it happened due to large hematoma and reabsorption of that hematoma, which led to drop in hemoglobin, drop in blood pressure. There was breakdown of RBCs leading to excessive heme metabolism and increase in bilirubin levels as both the conjugated and unconjugated hemoglobin, bilirubin levels. And sometimes a similar reaction can be seen with gram-negative sepsis, where there is exaggerated humoral and cell-mediated response leading to increased levels of cytokines like TNF and interleukin-1 and 6. And these endotoxins can activate complement cascade leading to hemolysis and coagulopathy, which this where the signs and symptoms may mimic acute hemolytic transfusion reaction. So some of similar conditions where there are mimicking signs and symptoms, like in case of gram-negative bacterial sepsis and infusion of IV cefotetan, where there was gross hemoglobinuria, and this case was reported in American Journal of Hematology. Patient receiving IV iron dextran, there can be fever, chills, and red color serum. So these are called pseudo hemolytic transfusion reactions. And the learning points from case 2 is the suspected transfusion reaction should be evaluated thoroughly, and the reactions that are associated with blood transfusion may not always be due to transfusion per se. And even negative findings are important. We need to convey it immediately to the clinicians so that they can look for other causes for those signs and symptoms. Febrile non-hemolytic transfusion reactions are quite common after transfusion. So the patient will generally have increase in body temperature around 1 degree Celsius higher than the pre-transfusion level. Symptoms typically appear towards the end of the transfusion, and 5 to 10% of the reactions present within 1 to 2 hours of transfusion. So the basic pathophysiology for febrile non-hemolytic reaction is the increase in circulating cytokines levels. So it could be due to the transfused leukocytes or that are accumulated in the blood product during storage. So the cytokines generated in the stored cells or the cytokines that are produced in vivo, whenever it exceeds the threshold level, patient can experience fever. So biological response mediators such as interleukin 6, 8, TNF-alpha, and RANTES, etc. can mediate febrile non-hemolytic transfusion reaction. Diagnosis is mainly by excluding HTR and the septic transfusion reactions. They are managed using antipyretics, and prevention can be done using leukodepleted blood products. So when I say leukodepleted, there are different types of leukodepleted methods of leukodepletion. First, I would like to discuss about the 3 types of leukodepletion. Here, I have shown illustrated the pre-storage method of leukodepletion, where we filter the blood before preparing components, and this filtered unit is stored at blood bank. Whereas post-storage leukodepletion means we collect the component, collect the blood, prepare components, and store at refrigerator. and filtration is done post storage, that is within 48 hours of collection. Whereas in case of bedside leukofiltration, we collect the blood, prepare components, and do filtration while transfusing the blood component. So which one is better? Pre-storage leukodepleted blood component is preferred over post-storage or the bedside leukodepletion. This is because these leukofilters can remove only the intact leukocytes, but not the stored or the accumulated, the cytokines or even leukocyte fragments can pass through these leukofilters. So pre-storage leukofiltration is preferred because there is less accumulation of cytokines in the product. The risk of alloimmunization and transmission of virus is also minimized with pre-storage leukodepletion. Quality assessment is easier here and the efficiency is much better. So for preventing alloimmunization or febrile non-hemolytic transfusion reaction, always pre-storage leukodepleted products are preferred. Next, let us move on to case 3. A 45-year-old patient with chronic renal failure with a hemoglobin of 6 gram per dl. He received 2 units of red cells. 5 days after transfusion, patient appeared pale, mildly jaundiced, and had fever. On investigation, his hemoglobin was 3 gram, whereas pre-transfusion level was 6. Here, it dropped down to 3 gram, and indirect bilirubinemia was noted. Transfusion reaction workup was initiated for this case. So here, the patient has repeated 5 days after transfusion with these findings. This could be a case of delayed hemolytic transfusion reaction where the drop in hemoglobin level is noticed 3 to 10 days after transfusion, and it generally occurs in patients who are multiply transfused or with history of pregnancy, where they are alloimmunized against the minor red cell antigens. As you can see in this graph, they will have preformed antibody, which is at a level much below the threshold for detection of the antibody. So pre-transfusion testing like cross-match may not detect this level of antibody, so it will be compatible and the red cells will be transfused. Following transfusion, there will be an amnestic reaction leading to increase in antibody levels. So when you do post-transfusion workup, you will be able to detect these antibodies and identify these antibodies. The increase in antibody levels lead to destruction of the transfused cells, causing drop in the hemoglobin and delayed reaction. So on transfusion reaction workup, you can see a mixed field reaction on direct antiglobulin test, and indirect antiglobulin test will be positive in such cases. And you can even identify the antibody on antibody identification. And anti-KID antibodies are notorious for causing delayed hemolytic transfusion reactions. Let us move on to case 4, where a 65-year-old man developed shortness of breath and hypoxia following transfusion. So what are the differential diagnoses in such patients developing dyspnea following transfusion? It can be due to transfusion-related acute lung injury or transfusion-associated cardiac overload or transfusion-associated dyspnea. And in some of the very severe allergic reactions like anaphylaxis, they can have dyspnea. Transfusion-related acute lung injury is a syndrome where the patients will have dyspnea, fever, hypoxia, hypotension, and bilateral pulmonary edema. It generally develops within 6 hours of transfusion, and the presentation is very similar to ARDS, but it has got better prognosis. The pathophysiology is due to donor leukoagglutinins, the donor antibodies reacting to the patient's leukocytes at the pulmonary capillary level. So there can be sequestration leading to the damage to the pulmonary capillaries and pulmonary capillary leakage leading to pulmonary edema. So the recent hypothesis is two-hit model, where the first hit is due to the underlying condition. So there is a priming effect which leads to the rolling and adhesion of the pulmonary leukocytes at the pulmonary capillary level. And the second event is blood transfusion. So the component containing biological response mediators like lipids, cytokines, and immunoglobulins, when transfused to a patient who are already primed, can lead to TRALI. Principally, the diagnosis is mainly based on clinical signs and symptoms and its temporal association with the blood transfusion. Patients will have severe hypoxia and drop in saturation level. There will be bilateral pulmonary infiltrates and pulmonary edema. And according to the recent criteria to define TRALI, it is highly likely whenever cases have clinical picture that we have discussed along with positive serological finding. And it is probable when cases with positive serology, but there is other coexisting morbidity, mimicking signs. If it is said to be equivocal with cases with positive serology in the clear presence of lung injury due to other causes or fluid overload. Antibody screening tests of the implicated donors can be done, and such donors have to be deferred permanently. As a preventive strategy, we do not transfuse plasma from the female donors. We generally avoid such units. Now, management is mainly supportive in nature, like administering oxygen, and patients may require ventilation in severe cases. Another differential diagnosis for dyspnea following transfusion is transfusion-associated cardiac overload. The patients with cardiac insufficiency, renal impairment, or chronic anemia, infants and children are at high risk. It is mainly due to rapid infusion and due to overload. So it is important to estimate the dose of transfusion, and it should be proportional to the body mass. Even the rate of transfusion is important. As per recent ABB guidelines, for RBC infusion, the rate can be around 4 ml per minute, whereas for FFP and platelet, it can be 300 ml per hour for a patient. So clinical presentation mimics TRALI. And as per recent Haemovigilance data, transfusion-associated cardiac overload was the most prevalent cause of transfusion-related mortality. But luckily, this is a preventable transfusion reaction. If we monitor the dose and the rate of transfusion and adjust it to the body weight and identify the high risk category of patients, then we can definitely prevent TACO. This is the recent diagnostic criteria for TACO released by ISPT and American Association of Blood Banking, where patients are classified with TACO. They exhibit the following signs and symptoms. The onset of reaction is within 12 hours of transfusion. Along with that, they can have respiratory system involved, like acute or worsening respiratory compromise, the evidence of acute or worsening pulmonary edema, based on the clinical and physical examination, as well as the radiographic chest imaging findings. The cardiovascular system symptoms include tachycardia, hypertension, increased JVP, And there should be evidence of fluid overload and positive fluid balance. And some of the biomarkers provide supporting evidence, like BNP, that is natriuretic peptide. It can be B type or N type of BNP. Brain natriuretic peptide is a neurohormone. It is produced in cardiac ventricles in response to the stretching. So whenever there is overload, there is stretching and increased release in BNP. So BNP can be a marker when you have to differentiate between TACO and TRALI. In case of TACO, it is quite high. It's more than 1200 picogram per ml, whereas in TRALI, it can be much lesser. So TRALI patients can present with fever and hypotension, whereas in TACO, they will not have fever, and there will be hypertension compared to TRALI. So these are the minor differentiating features between the overload patients with the TRALI. Another differential diagnosis for patients presenting with respiratory distress following transfusion is transfusion-associated dyspnea. So again, this is a diagnosis of exclusion. You need to rule out TRALI and TACO, and the unexplained cause for dyspnea following transfusion. Finally, you can conclude it as TAD or transfusion-associated dyspnea. The allergic transfusion reactions are quite common, especially the milder ones like itching and urticaria are quite common following transfusion. It is generally due to the allergens that are present in the blood components like plasma proteins or IgA, haptoglobin, or the complement factors. Sometimes the food allergens can even trigger allergic transfusion reactions. Rarely, it can be allergen-independent pathway mediating severe reactions. So management is, first of all, we need to stop the transfusion and do not restart after giving anti-allergics, because it is already proved that there are some allergens in that component. And if it is very severe reaction, then supportive management, especially for anaphylaxis, you may have to give epinephrine and other drugs. So to summarize the session, first of all, for any transfusion reaction, the early recognition is very important. So we need to monitor the patient very closely while giving blood and blood components. The first step is to stop the transfusion and initiate the reaction workup. Also try to find the root cause for the reaction, classify the reactions and manage them accordingly. And most of the fatal reactions are due to preventable mistakes or the preventable causes. So take a corrective action and the preventive measures at your center so that we can prevent the recurrence of such fatal reactions. Thank you.
Thank you, ma'am, for such a enlightening presentation. And ma'am, like some of them are watching it on YouTube live also, ma'am. So some of them had messaged. One of the question was in your experience in your center, they wanted to know which transfusion reaction you often come across.
Yes, we generally see allergic transfusion reactions like itching and urticaria. That's the most common one, followed by mild fever. That's febrile transfusion reactions. Fortunately, we did not have mismatched transfusion or hemolytic transfusion reaction since long time.
There's one more question, and
Yes.
the cases they wanted to know where leukodepleted blood will be useful in which cases, ma'am?
Yeah, the indications for leukodepletion of blood products is mainly to prevent alloimmunization. In case of patients who are supposed to receive multiple transfusions or patients who are candidates for transplantation, then in such cases you have to give leukodepleted products. In patients with recurrent transfusion reactions like febrile reactions, you can use the pre-storage leukodepletion to prevent such reactions in future. So these are the main candidates to receive leukodepleted blood products.
One more question is how to improve the transfusion reaction reporting, ma'am? Because sometimes, is there any standard set of guidelines or
Yes, the Hemovigilance program is now quite active. We need to train our ground force, mainly our nursing staff and the interns who monitor the transfusion process, or the clinicians. They need to identify the reaction and report it to the transfusion medicine department. In most of the cases, it's only the tip of the iceberg that is getting reported. So the training and further, we need to have one-to-one communication and also stress the point during hospital transfusion committee meetings. So repeated request and training, I think, will help in improving the reporting rate.
Thank you, ma'am. If there are no other questions, we'll move on to the second session of today's webinar. Thank you, ma'am. And for the next session, I would like to invite our Dr. Das sir. He is professor of pathology at Sri Devaraja's Medical College, Kolar, and he also has a vast experience in blood banking of almost 10 years. He has undergone special training on cytological techniques at St. John's Medical College, Bangalore. He has several publications to his credit and has authored several books. He is currently pursuing his PhD in blood banking. His field of interest include medical education, immunohematology, and cytopathology. Over to Dr. Das.
Sir Kumar sir, thanks for joining the webinar.
Good morning, everyone. First and foremost, I would like to thank the Department of Pathology, our HOD, Madam Kalyani, and the Professor Dr. Hemlata, the Blood Bank Officer, for requesting me to give a short talk on hemovigilance. I would also like to welcome my senior colleague, Dr. Shastri, whom I know, I've met sometimes in the conferences. It was an excellent lecture, madam. Thank you so much. And now I will begin my lecture on hemovigilance. Hemovigilance is a relatively a new concept, and in this concept, we are going to talk about introduction, how hemovigilance is working in India, what are the working patterns of hemovigilance program of India, what are the objectives and types of adverse reactions and their outcomes and recommendations. Now, the word hemovigilance was first coined in France in the year 1903 with the existing term of pharmacovigilance. It is derived from the Greek word hema, that means blood, and the Latin word vigilance means watchful or paying special attention to or keep watching. So this is the word that has been derived from the Greek and Latin combination. And according to WHO, or the International Hemovigilance Network, or the International Society for Blood Transfusion, hemovigilance is defined as set of surveillance procedures covering the whole transfusion chain from the collection of blood units and its component till the follow-up of its recipients, intended to collect and pass information on unexpected or undesirable effects resulting from the therapeutic use of labile blood products and to prevent their occurrence and recurrence. So this is the broad definition of hemovigilance, which says that emphasis should be used on its occurrence as well as recurrence. So we should take measures to prevent its occurrence and also on its recurrence, including unexpected or undesirable side effects. So it calls for constant vigil. At present, most of the developed countries are implementing hemovigilance system under different names. In UK, it is short, that is called as serious hazards of transfusion. In Netherlands, it is called as transfusion reaction in patients. In Canada, it is called as transfusion transmitted injuries and surveillance. And in India, it is called as Hemovigilance Program of India. So there are so many names in so many countries, but the ultimate objective is to prevent the occurrence of transfusion reaction, and if it occurs, it should not reoccur again. So this is the whole message of the hemovigilance program. Now, coming to the hemovigilance program of India, it is a centralized, well-structured program for monitoring adverse reactions associated with transfusion of blood and administration of blood products. Hemovigilance program of India was implemented across the country in 90 medical college in the first phase. At present, more than 200 centers are covered under this program, including our blood bank. So the National Coordinating Center for Hemovigilance Program is at National Informatics Biologicals at Noida. And because of Hemovigilance Program of India, we are also a part of International Hemovigilance Network, that is only after Japan. So only 2 countries are part of it, Japan and India. So this is the evolution of the hemovigilance program. Initiation phase was around 2012 to 2013. Then followed the expansion and consolidation phase, that is the 2013 to 15, followed by expansion and maintenance phase between 2015 and 16, followed by the optimization phase, that is 2016 to 17. So the hemovigilance program of India has evolved over a period of several years, right from the initiation phase to the optimization phase. Now the optimization is over and we are into full-fledged having a hemovigilance program of India. Now these are the state-wise centers we have enrolled for hemovigilance program of India. Karnataka, the number of 27 is the highest number. So across various states we see, but we are among the highest. Now how does it work? Under the hemovigilance system, there are certain definitions, there are certain terms that needs to be kept in mind. First is monitoring. Monitoring of the whole transfusion chain means according to the country's policy. So the monitoring should be based on the set rules and regulations which the country follows. Identification of lacunas in the whole step of transfusion chain. This is followed by identification of deficiencies. First is monitoring as per these rules and regulations existing on the country, followed by identification of the steps of the deficiencies during the implementation of the various steps. This is followed by reporting of the unexpected or undesirable effects resulting from the therapeutic use of labile blood products. So if any transfusion reaction happens, it should be immediately reported to the concerned authorities. So this is, as Madam was telling previously, this is very, very important. It should be brought to the notice of the blood bank as well as to the clinicians that this has occurred and what are the reasons for that. These are the things, this is very, very important. Adverse event is an untoward incident that occurs. Near miss is something which could have affected the blood transfusion, but unfortunately it did not happen. So it could, a transfusion reaction could have been attributed to near misses, but fortunately that lacunae was detected, that mistake was rectified, and the disaster was averted. Now, this is followed by updating. That means continuous updating of information should be occurring regularly so that to prevent their occurrence and recurrence of various transfusion reactions. Now, coming to the Hemovigilance Program of India, in particular, it has two objectives. Number one objective is to track adverse reactions or events and incidents associated with the blood transfusion and blood administration. This is to track adverse reaction, events, and incidents associated with blood transfusion and blood product administration. That is why to fulfill the number one objective, reporting is of so much importance. So we have to keep a track so that it doesn't occur, and if it occurs also, it should not recur again. Next objective is to help identify trends, recommend best practices and intervention required to improve patient care and safety while reducing the overall cost of the healthcare system. So we should try to give the optimal patient care to all sections of society, including the poor patients. So the poor patient's safety and security should never be neglected. We should try to give the optimum services with the best possible interventions. Now this is the flow chart. The Hemovigilance Program of India is not just restricted to medical colleges or the government sector, it is open to everyone. So the private hospitals, nursing homes, the medical institutions, medical colleges, anywhere and everywhere where blood transfusion occurs are invited to participate in this program. They are supposed to report to the National Coordinating Center or the National Institute of Biologicals, which will be the main nodal center. This main nodal center will have an advisory committee and a group and a core group. This is followed by the National Coordinating Center under the guidance of Indian Pharmacopoeia Commission, Ghaziabad, which will be also under the Drug Controller of India's control. This is followed by the stakeholders. The stakeholders are the patient healthcare professionals, the blood bank, the NACO, and the SBTCs. So anyone involved in the blood transfusion chain is totally involved in it. Now coming to the hierarchy of hemovigilance, first we have the Adverse Drug Reaction Monitoring Committee are those medical colleges and institutes, hospitals and blood banks that are registered with the Pharmacovigilance Commission Coordinating Center for reporting adverse reaction. The first is the most important Adverse Drug Reaction Monitoring Committee, where the registered institutes are incorporated. So before we participate in the hemovigilance program, we have to register to the commission. Next, the core group of advisory committees are formed, which finalizes the hemovigilance transfusion reaction reporting form and the guidance document. There is also a core group which has a standard set of protocols, standard set of documents, which has to be the basis of transfusion reaction form and guidance documents. So this also has to be documented properly so that we get uniform documentation which takes care of all the essential details that are required for analysis of a particular transfusion reaction of various etiologies. Then we have the National Institute of Biologicals, which is the ultimate coordinating center to collate and analyze data with regard to hemovigilance. Now, what are the responsibilities of the medical college and nursing station? If any transfusion reaction is suspected, the concerned nursing staff should document and report it immediately to the concerned physician. As has been highlighted time and again, reporting is a must, and for reporting, monitoring is also very essential. So if a transfusion reaction is suspected, immediately it should be reported to the concerned authorities. Details of such a patient and product related information should be documented properly. All the necessary documentation should be done in proper way. Document transfusion reaction details and submit to the Department of Immunohematology and Transfusion Medicine. Then, after the submission, assess the imputability level, the responsibility level, what went wrong, how it went wrong, and who was responsible for that. The imputability is imputability level detects the attributary level, who is attributable for that mistake. This is followed by keeping the details of complication and also investigation under close watch. So it should be thoroughly investigated and all the complications should be noted down. So these are the 4 or 5 basic steps that needs to be followed in every center where a blood transfusion occurs and a transfusion reaction is suspected. First and foremost, it should be reported to the concerned authorities without any delay, and while reporting, it should be done in a uniform format which takes all the necessary details into consideration. And once it is reported to the blood bank, the attributes, what went wrong, how it went wrong, and who was responsible for that should be analyzed in a scientific way. And while doing this, we should also keep a track of complications and also undertake suitable investigations for that. So this is the transfusion reaction form, the uniform form that we every month and we report. This is our license where we have been enrolled as a certificate of participation. It was the year 2018. We have enrolled as this. This is the same thing which they have given a certificate of certification or what all we look after. And as I was telling, imputability means an adverse event or a reaction a recipient may be attributed to the transfusion. Various levels are definite. Definitely possible means when there is a conclusive evidence beyond reasonable doubt that the adverse event can be attributed to the transfusion. So many reactions can occur due to transfusion and many reactions may not be responsible only due to transfusion. If a reaction occurs, we have to devise and ways and mechanism so that attribute factor can be definitely determined. So for that, we have certain sets of definitions. One is definite, another is probable, that is likely. Means when the evidence is clearly in favor of attributing the adverse event of the transfusion reaction. So it may not be certain, but most likely it could be. This is the second step. The third step could be possible when the evidence is indeterminate for attributing the adverse event to the transfusion or an alternate cause may be existing. These are the different levels of imputability. First is definite, when there is no doubt about it, it is 100% sure that this is only responsible for the reaction. Followed by probable, where it is most likely. This is followed by possible, when it is an indeterminate factor, where it may be, it may not be. Unlikely is doubtful, when the evidence is clearly in favor of the attributing the adverse event to causes other than transfusion reaction. So unlikely means transfusion reaction is not responsible for the clinical feature that the clinicians are suspecting. Excluded means when there is a conclusive evidence beyond reasonable doubt that the adverse event can be attributed to causes other than the transfusion. So these are the 5 terms which are very, very important while reporting and assessing the hemovigilance report. This is the standard form that they have given from the Noida Center for reporting all suspected transfusion reaction form every month end. Now the flow chart for reporting serious adverse reaction in blood transfusion. What happens in the medical ward, what blood bank should do, what the clinical associate should do. This has already been covered, but just for the completion's sake, in medical ward, as soon as the adverse reaction is noted by the physician or nurse, the documentation should be done in form number 1. This is followed by filling up the form number 2 and forward at the form and send the blood and the transfusion set to the blood bank for further investigation. Here, the further investigation will be sent along in the hematology lab for CBC and plasma, hemoglobin, urine hemoglobin and coagulation screening. The biochemistry lab will also be involved for assessing the renal function test and the liver function test. Then also we have to send the post-transfusion blood in special culture bottles to microbiology lab to rule out any bacterial contamination or sepsis. So in the blood bank, these things should be done in the medical ward. Now in the blood bank, the transfusion reactions is to be investigated as per the transfusion reaction workup forms. Findings are documented. Compilation of the reports from biochemistry lab and microbiology lab are done, and accordingly the results are investigated. In the blood bank, the imputability level has to be assessed. This is one of the main job of the blood bank with regard to hemovigilance, is that assessing the imputability level, who was responsible and what was responsible, so that this thing doesn't recur again, and then calling up and talking to the physician of the respective medical ward. The clinician should also be kept in the loop, and he also should be taken into confidence. Enter the details of the transfusion reaction for the traceability and involve, and the technical associate for the hemovigilance program should be intimated. So we should never forget to inform NOIDA about it. Now NOIDA is the hemovigilance program of India, and we should inform them immediately when a transfusion reaction occurs. So there is a need for reporting adverse reaction in transfusion. In true sense, a reporting is a tool for obtaining information which can be used to improve product safety. So much emphasis has been laid on reporting. Reporting means very, very important, immediate, to improve the safety of the product, and a national reporting system can be used as a tool to advance public policy concerning patient safety, so that what all inputs, what all features that we see in while reporting, those data can be considered as an input for developing public policy in order to ensure safe transfusion practices. Reporting can also identify hazards and risks and provide information as to where the system is breaking down. While reporting, we can also identify the lacunae which needs further improvement, so that further improvement can be taken out, and such patient safety, and as such patient safety can be further improved, and the risks of transfusion reactions can be minimized. This can help target improvement efforts and system changes to reduce the likelihood of injury to future patients. So all these things will add on to our efforts of preventing transfusion reaction in future and improve the transfusion safety. Reporting of suspected transfusion adverse reaction in a timely manner facilitates the effective risk management also. Here the word timely manner is very, very important. Once a reaction occurs, it should be reported and investigated immediately. So delay should not be done, so that we can take effective steps at the earliest to ensure optimum results. In most systems, only the adverse reactions are reported, but also adverse events also needs to be reported. Reporting of all adverse events results in better for hemovigilance purpose and raises awareness. Donor hemovigilance also needs to be taken into account to reduce donor complications, which is very, very important to increase the frequency of donation and improve donor satisfaction. Till now, what was being described was patient hemovigilance, or hemovigilance to be undertaken while the bedside while giving the transfusion. Of late, donor hemovigilance has also taken up a very important role, where we look into the donor welfare. So the donor hemovigilance or donor discomfort, donor preference also needs to be taken into account, and this is very, very important to promote voluntary blood donation and to improve donor satisfaction, so that we have a pool of regular repeated donors who regularly visit our blood bank to donate blood. So what happens to the report that is submitted? The causality assessment is carried out at the medical college under the hemovigilance program. We do it under the transfusion hospital transfusion meeting. Information is collected in the transfusion reaction reporting form, which will be forwarded to the National Coordinating Center Hemovigilance at Noida, so that software Hemovigil. This data will be collated and analyzed to identify trends and recommend best practices and interventions required to improve the patient care and safety. So every month, so we get a message from the Noida Center asking us to fill up the hemovigilance form quickly. In fact, they send a deadline also, and if we miss the deadline, they send a reminder to us also. You please fill it up and send it back. All this information that they are collecting is of importance to draw up public policy to improve blood transfusion safety measures. Now, what we are doing, we have also started out in Kolar a study, which is a cross-sectional study in our hospital. The purpose of the study was to assess and create awareness about hemovigilance among doctors and healthcare providers. So, as Madam was also telling previously, that awareness and their participation, particularly among the clinicians, is very, very important to improve the transfusion safety. So, we had done this study to know the knowledge, attitude, and perception of hemovigilance among the healthcare providers. A pre-validated questionnaire was prepared and given to all the healthcare providers, including doctors. Both open and close-ended questions were included, and 16 questions out of these 7 questions were regarding knowledge, 6 for attitude, 3 for practice about hemovigilance was prepared. After obtaining the consent, the participants were selected by random sampling method. And for answering the questionnaire, we had given them 20 minutes. And the study was done actually during the period of July 2019 to December 2019. So these were some of the results which I would like to share with the esteemed gathering. So the table 1 shows the knowledge related questions, which shows that it is evident that only 35% of the team were 35% of the participants were aware about the transfusion reaction reporting system in India. So the level of knowledge, level of information is very poor, as the clinicians only 35% was aware. So reporting of transfusion reaction to the concerned department was the response by majority of the doctors, and 90% of them supports the need for transfusion committee in our hospital. So first is that we saw the transfusion of blood products will reduce the transfusion reaction. Do you agree with this product? This is 75% said yes. And most of them supported that transfusion reaction reporting system should be there to improve the transfusion system. So level 2, practice related questions. So only 35% have attended the CMEs and seminar on hemovigilance. So only 35% have attended. No is 65. So a broad majority have not yet attended any CME or seminar on hemovigilance. So their level of knowledge is very below satisfaction. So have you ever reported any transfusion reaction? 88% said no. So that means some degree of underreporting is still going on, and all the cases are not being reported in due format. Have you documented any transfusion reaction? However, they said no. 90% said no, they have never documented 90%. This is a serious lapse which calls for urgent steps for implementing the knowledge of hemovigilance program of India. Another table shows the factors which can improve the training transfusion reaction reporting system. 96% of them said the training of healthcare staff, the proper training and motivation is very, very important to improve the reporting system, particularly the paramedical staff and the junior doctors. Then also is important is availability of reporting forms in the wards. So if they want to report, the reporting format should be easily available in the various wards. So these were the measures they suggested. Someone also suggested implementing a mobile app for reporting. So that is also 75% of the students also suggested that mobile app would have been very important to bring the transfusion reaction to our immediate notice. Then this is followed by factors which discourage reporting. This is also a very important factor. This has to be taken care to improve the percentage of reporting. So this reveals that lack of knowledge, inadequate time for reporting, liability issues, and poor knowledge. All these factors are equally responsible, which prevent immediate reporting of transfusion reaction. So one is the legal liability issues. They think that if they report, some vindictive steps or some legal problems may arise. So they try to skip this issue and try to cover up. So hemovigilance program assures them that there is no question of any vindictive measures to be initiated against anyone if a transfusion reaction occurs. So that has to be reported, that has to be told to all the participants, and circulation of knowledge regarding this should take place to the most ground workers so that they are less scared and they come forward to report transfusion reactions. These are the tables which show that we have studied. Mostly our study was focused on the doctors and nurses. We have included pharmacists also. So this figure shows that 50% of them strongly agree that reporting transfusion reaction is important. So in our study, they realize that 50% of the staff or the students realize that reporting is very, very essential. This figure reveals that the various factors which discourages the reporting, as earlier told, the lack of knowledge and legality issues. That is why they do not report. And coming to the discussion part of it, that we have a hospital transfusion committee, and this one of the mandate of the hospital committee is to see the hemovigilance system to ensure safe transfusion practices. The doctors and paramedical staff are sensitized about the hemovigilance system, and also monitoring and reporting of the adverse events are encouraged. So in our institute, the maximum problem occurs due to failure to follow the procedure and lack of sufficient knowledge and inadequate or unclear procedures. So all our problems that we face in our institute is because of procedural delays or procedural bottlenecks, which holds up the proper hemovigilance implementation of the proper hemovigilance program. So hemovigilance provides the required modification in the transfusion policies to improve the standard and reinforces the data and quality of whole chain from the start of donation process to the end of the transfusion procedures by taking into account all the necessary remedial and preventive measures towards the risk reduction in blood transfusion. So, however, one most important point of late is that there is significant increase in the number of centers for reporting of transfusion reaction under the Hemovigilance Program of India. Thank you. If there is any questions.